And so as we look at the approach from a pulmonologist standpoint for the workup, we ask 3 questions. Is there a discernible cause for the ILD? And if not, does it appear to be idiopathic pulmonary fibrosis? And then finally, if neither of the above, should a biopsy be done to further decipher the underlying process? What's involved in the workup? Well, the first things that we ask is, has this been around for a long time, or is this acute? Is it acute or chronic? Are there possible exposures? This might involve the underlying job of the person, hobbies, things like, it might sound very eclectic, but glass blowers. Now, I spent 22 years in Chicago, and silicosis and asbestosis were very high on the list because of the steel mills. Certainly mold from hot tubs or moldy basements. We ask ourselves about the comorbidities, and you'll see as we move forward why this becomes so important, but it does become a question of pattern recognition because we know that there's a higher predilection to certain comorbidities with this diagnosis and the alternative diagnoses as well. And then we look for evidence of autoimmune diseases, things like mechanic's hands or sclerodactyly or arthritis. We're certainly going to look at the spirometry and the diffusion capacity. This helps us discern the level of restriction and whether it's present or not. Laboratory work. This is highly important in discerning whether or not an autoimmune disease is present. Now, it's true that some of this lab work, such as an ANA and an ESR, may be elevated in the elderly, but the other ones become very, very specific and very important to certain disease processes. Things like an SCL70, which will be highly indicative of an underlying scleroderma process, or an SSA or an SSB, which would be suggestive of a Sjogren's. Alternatively, something like an anti-synthetase testing with an anti-Jo would suggest polymyositis. But most importantly is the high-resolution CT scan, because it helps us get at the pathology without needing a biopsy. We know that if there's a usual interstitial pneumonia pattern on the CT scan, it's almost certainly going to be there on the biopsy as well. And what we're really trying to discern is whether or not something else may be present, such as a non-specific interstitial pneumonia pattern or a hypersensitivity pneumonitis pattern. All right, when we look at the CT scan, we get more information than just the biopsy possibilities. Our radiology colleagues are very good at helping us. And so some of the first questions are really corollaries to the underlying pathology. Is it reticular or is it nodular? If it's reticular, it's going to suggest an interstitial process. If it's nodular, it's going to suggest a granulomatous process. If it's interstitial, is there ground glass? Ground glass would represent an alveolitis. And where is it predominant? Upper versus lower, peripheral versus central. You see, upper lobe predominance would suggest things like silicosis. A peripheral process would suggest something more like a usual interstitial pneumonia pattern, whereas a central would exclude it. And the truth is, as I said, our radiology colleagues will be able to make a definitive diagnosis here 60 to 80% of the time, depending on the underlying pattern. What's the utility of the lung biopsy? This is going to vary greatly depending on what you think it is. We know that a transbronchial biopsy in the setting of something that's granulomatous could be very high. An example would be sarcoidosis, where we know that 90 to 96% will be attainable by transbronchial biopsy. But for something that's not going to be granulomatous, the transbronchial biopsy may have very low yields, under 38%. And certainly a video-assisted thoracoscopic biopsy or an open lung biopsy is not always required. But when it is, we want to get 2 sources. And that's to get confirmatory biopsies so that we're not biased by acquisition. And areas of honeycombing should be avoided because those are always going to represent end-stage lung. Now, the bronchoalveolar lavage fluid may be useful in certain instances, primarily infectious etiologies, but other things like pulmonary alveolar proteinosis, certainly things like a suspected malignancy, or drug-induced lesions such as pulmonary interstitial eosinophilic syndromes, where you might see a rise in the underlying eosinophil counts. So now is a challenging time for IPF more so than ever to really make the right diagnosis. And this is because making the right diagnosis has become not only a constant challenge, but has more impact now than it ever has.